presentation معانا من ABCDE Cardiology Boards. سريعا كده أنا أحمد شبل Chief Resident at University of Alabama in Huntsville. واحنا part of big group اللي هو ABCDE Group. هدفنا non-profit organization إن احنا بنعمل collaboration ما بين الدكاترة اللي موجودين في مصر وفي الوطن العربي واللي موجودين في أمريكا إن شاء الله. الهدف من السيشن ديت إن احنا هنناقش حالات كارديولوجي، وما بين الباناليست اللي موجودين معانا اللي هم US attendings موجودين معانا with different areas of expertise. وكمان معانا التيم بتاع كايرو يونيفرسيتي هو اللي هيبقى البريزنتر توداي. هيبقى موجود معانا دكتور سالم بدر، هو الميديكال دايركتور اوف ستراكشرال هارت ديزيز في مارشال يونيفرسيتي. وهيبقى موجود معانا كمان دكتور احمد سامي، هايبرتروفيك كارديوميوباثي سبيشالست في الاسكا. وفي كمان موجود معانا دكتور اسامه محمود، هو هيجوين اس سون يعني، هو ادفانسد هارت فيلير سبيشالست كمان في بابتست هارت هوسبيتال. وفي موجود معانا دكتور عمرو عيسى، هو اكسبرت ان ستراكشرال هارت ديزيز يونيفرسيتي اوف فورمنت. التيم بتاع كايرو يونيفرسيتي هيبقى موجود معانا البريزنتر توداي دكتور احمد عبد الحميد، هو كايرو يونيفرسيتي اسيستنت ليكتشر في كايرو يونيفرسيتي. وكمان موجود معانا احمد اسامه اسيستنت ليكتشر كايرو يونيفرسيتي، برضو كان هو البريزنتر المره اللي فاتت. وكان موجود معاه ابرام، مش عارف ابرام موجود النهارده ولا لا، بس يعني يعني عملوا سيشن كويسه جدا المره اللي فاتت. ان شاء الله السيشن ديت هتبقى يعني افضل وافضل باذن الله. ومعانا كمان من الاي بي سي دي كارديولوجي بوردز موجود معانا كمان خالد، هو موجود معانا، هو second year resident في شيكاغو internal medicine. وهو كمان aspiring ان هو يبقى كارديولوجي فيلو. فان شاء الله هنبدا السيشن بتاعتنا يعني. شكرا لكل اللي حضروا، وشكرا لكل الباناليست اللي هم يعني معانا النهارده، يعني شكرا على وقتكم. فان شاء الله كده يعني لو حد عنده اي اقتراح، احنا لسه بنبدا يعني، دي تاني سيشن. السيشن الاولانيه بصراحه كانت عملت يعني فرق كبير، والناس كانت الفيدباك كان كويس جدا، فان شاء الله السيشن دي تبقى افضل وافضل باذن الله. دكتور سامي، اي حاجه حابب تضيفها قبل ما نبدا؟
لا والله، ده يعني مجهود عظيم، ويعني the more of this يعني the better يعني. ويعني أنا شايف إن في حضور وفي ناس engaged من هنا ومن هناك من كل حتة صراحة يعني. فيعني it's a good learning environment. We all learn from each other and just be productive إن شاء الله.
باذن الله باذن الله. دكتور عمرو عيسى، يعني ويلكم تو ذا جروب، يعني شكرا على وقت حضرتك.
لا، شكرا على الانفايت. انا ما قدرتش اخش المره اللي فاتت معاكم فبعتذر، بس انا مبسوط جدا ان في حاجه زي دي الصراحه. يعني انا throughout my training كان كل attendings بتوعي مش مصريين بس عرب. they have such a platform. فلسطينيين، سعوديين، اردنيين. وساعات كتير فكرت ليه ما بقاش عندنا حاجه زي دي، يكون connection between احنا هنا باليو اس وزمايلنا back home. ف يعني تشكر على المجهود وعلى الفكرة، وأتمنى بس كل مرة ناس كتير تحضر بإذن الله وشكرا جزيلا.
شكرا جزيلا دكتور عمرو. في موجود كمان معانا دكتور سالم بدر، هل هو موجود حاضر معانا ولا لسه؟ ماشي، تمام. في موجود معانا كمان دكتور أسامة محمود، هو جون اس سون. في أحمد خليل. مستعد يا أبو حميد؟
انا جاهز وانس ان احنا هنبدأ نجهز ان شاء الله.
طيب تمام. حابين نبدأ دلوقتي على طول؟
يلا نتوكل على الله.
تمام
اوكي، انا I will start sharing السكرين بتاعتي.
تمام. احنا هنحاول نخلي السيشن يعني على قد ما نقدر تبقى ساعة. الأول هيبقى فيه البرزنتيشن، والباناليست هيدسكس الحالة مع دكتور أحمد. ولو في أي أسئلة في نهاية السيشن يعني ممكن نجاوب على كل الأسئلة. أنا مش عارف هل الحاضرين اللي موجودين هل هيبقى عندهم أكسس إن هم يبعتوا أسئلة، الشباب بتوع الأي تي؟
عادي ممكن يبعتوا.
تمام، خلاص بإذن الله، خلاص نتوكل على الله.
مش عارف السكرين بتاعتي كده. do you see my screen؟
واضح.
أنا شايفها مظبوط.
هو الترانزيشن شغال؟
مظبوط تمام.
اوكي تمام. So I'm extremely grateful for the chance of being here today. We hoping إن احنا we all gain benefit today. So I'm Ahmed Khalil. I'm a cardiology specialist, assistant lecturer of cardiology at Cairo University. Today we'll be talking about prosthetic valve thrombosis in pregnancy, and we'll be discussing how it is some sort of a dilemma with no correct answer to go or to pick, and no single right way to do the things for all the patients. So our patient is a 31-year-old female housewife married with 3 children. The youngest is 2-year-old, and she had a first trimesteric missed abortion when we first saw her. She also had mitral valve replacement 8 months ago on top of rheumatic mitral stenosis. She had no special habits of medical importance. The chief complaint cardiac-wise when we saw the patient was shortness of breath of 2 months duration, and this was coinciding with her unplanned pregnancy. She was pregnant of 2 months duration. Starting with that, she started to complain of shortness of breath, gradual onset, progressive course, exertional mainly, relieving with rest, and in the last 2 weeks before we saw her, she started to have orthopnea. The patient has been following with her obstetrician. During her follow-up, she had a CPC showing anemia. It was microcytic hypochromic, iron deficient, and she had iron supplement. Unfortunately, there was no echocardiography done at this point. Regarding her anticoagulation regimen, her obstetrician did a very traditional thing that many of us do. He discontinued the Marivan or the warfarin and switched her to low molecular weight heparin. Therapeutic dose 1 milligram per kg every 12 hours, the presumably therapeutic dose, on which she was not compliant, mainly due to financial reason, because enoxaparin requires some sort of a budget here in Egypt. Her dyspnea was mainly attributed to pregnancy, anemia, and no further workup was done at this point. In the 8th week of pregnancy, the patient during her routine follow-up was found to have a missed abortion, and she was advised with surgical evacuation, and that is when she was referred to our institute, Cairo University, being a tertiary care center. The patient was referred to us as a cardiology department for preoperative assessment, because first she had a metallic prosthesis, second because she was already symptomatized. We did not have any relevant cardiac symptomatology, and her other system review was significant for postural cough. She used to have cough on lying flat, and she also had retrosternal burning pain, impressive of gastroesophageal reflux disease. No other significant symptomatology. Past history was irrelevant, and her surgical history, as already stated, she had mitral valve replacement 8 months ago on top of rheumatic mitral stenosis. Her prosthesis was St. Jude prosthesis 27 size, and she also had a tricuspid angioplasty ring. Drug history shows supposedly be on therapeutic enoxaparin and bisoprolol 5 milligram. She has been receiving it since her surgery. Examination was remarkable for orthopnea, and she also had big pulse volume, mainly attributed to anemia and the hyperdynamic state of pregnancy. She was also a little bit tachypnic. Her respiratory rate was 25 cycles per minute. Otherwise, she had unremarkable general examination. She was pale, and she also had lax calf muscle. I think that we usually check in this neck females, pregnant females. Cardiac examination was remarkable only for well audible metallic S1, and no other additional sound or murmurs could be appreciated. These are the labs of the patient. Throughout the first 3 to 4 days of hospitalization, I reported the mean values. Her hemoglobin, she was anemic, 8.1. It was microcytic hypochromic, as I already stated. She had a subtherapeutic INR 1.4. She was iron deficient. TSAT was 14. CRP was 61. Later on, it fell to 23 over the course of 3 to 4 days. Procal was 0.1. Blood culture, no growth. D-dimer, this was on presentation, 0.4. And it is negative. Reference is 0.5. This is the ECG of the patient. I hope that you see it well. It is a sinus rhythm with one-to-one conduction, a little bit prolonged PR interval around the 6 small squares. Nothing else remarkable to be mentioned here. So let's summarize what we have exactly. We have a pregnant female with missed abortion complaining of dyspnea, and we have a non-well anticoagulated mitral valve prosthesis, and we have anemia. Would you like to engage in a discussion here, or should I just continue? Do you hear me?
Let's
تمام.
keep discussion to the end. I think so.
Okay. Okay, so at this phase, we usually, in a dyspneic pregnant female, we try to think what does she have. But this is not just a dyspneic pregnant female, it's a dyspneic pregnant female with a metallic prosthesis. So prosthesis should be a priority for us. Pulmonary embolism is another possibility. Anemia and general condition could be, but let's start with the most important. So usually we start for patient with prosthesis, we start with fluoroscopy because it's easy and very feasible at our institute. So this is the mitral prosthesis, usually best visualized in the REO views, cranial in the most of the cases. So here we can appreciate a perfectly opening and closing prosthesis. The two occluders perfectly open, the angle is around 130, perfectly closed, I'm sorry, and perfectly open. They are almost parallel to each other. So by no means this is a stuck prosthesis. But we have from our experience and from the what we know from the guidelines that this is not just enough to check the fluoroscopy, because the fluoroscopy does not check the soft tissue abnormalities, does not tell us about the regurgitation, the thrombi, the panas, if it is there. So we proceeded for echocardiography, and this is the transesophageal echo. So just tell me that the clips are working in front of you. Clips
Yes,
are working?
working very well.
Yes.
Okay. So on your top left hand, this is parasternal long axis view showing normal left ventricular dimensions and very good contractility. We can appreciate the prosthesis with the shadowing artifact. You see my cursor with the shadowing artifact on the atrial side. Here on the top right hand, you can appreciate the two occluders of the prosthesis. And here, fortunately, they are perfectly visualized opening and closing. Here we have put color. It is mainly a diastolic flow. And here, as we already stated, that pulmonary embolism was amongst the differential diagnoses. So the right side here looks very well as a contractility. Looks fair, preserved, and it is not dilated. And I'm not sure if you can perceive the annuloplasty ring on both sides of the prosthesis. So further interrogation using the continuous wave Doppler. So here was the pressure half time was 217, and the mean gradient across the prosthesis peak and the mean was 20. I'm sorry. Peak and mean gradient across the prosthesis was 24 and 16. This is an image from an application that is used by our cardiothoracic colleagues. They used it to know the peak and mean gradients, opening and closing angle for various prostheses. It is called Valve PPM. It is made and maintained by Menopulus Heart Institute. So for our patients, we are by far exceeding what we should have. Our peak is 24 compared to 11 to 15 that we should have, and mean is 16 compared to the 5 to 7 that we should be having. So I wanted us to engage in a discussion here, but about what do you think is a differential diagnosis at this stage, and what should be the next step? Is this a good idea, or you want us to just proceed?
I think it's a good idea. If any one of the panelists want to participate, ask any question, that would be great.
Yeah,
Did we have?
I can start. Yeah, I think it's a very interesting case for a couple of things. You know, she had a mechanical valve 8 months before unplanned pregnancy, and did we have a good counseling about pregnancy in this young age, right? There's from the get-go here. The other thing which is interesting, when she had been on Coumadin and moved to low molecular weight heparin, now that transition because of the anemia, could we blame Coumadin in the first trimester as a cause for abortion or not? And then the third issue with her anemia, you see a little bit elevated CRP and dyspnea, and make me think a little bit about, do we have endocarditis, right? But also we don't have any systemic manifestation of fever as a reason to think about endocarditis, but CRP is high. That can be explained by pregnancy, but I will not exclude endocarditis as a differential diagnosis. Now, when you look at her vitals and look at her EKG, First of all, she has sinus, right? And she had a history of rheumatic fever and mitral stenosis. And usually they are not in sinus rhythm. Usually they have AFib. Second, she's sinus bradycardia and first degree AV block. And this is what make me think, are we dealing with endocarditis, or are we dealing with conduction abnormality with endocarditis? And if she's anemic, and I don't think she's on beta blockers, but why she's
She
bradycardic?
was.
Oh,
She
she's on
was.
beta. Okay,
She was in
perfect.
bisoprolol 5. I stated that in her drug history.
Awesome. Okay. So that's
Bisoprolol 5.
that's make it easier for me a little bit now, which is and then you move to I will do the same thing for the fluoro, and I agree, it completely looks fine. It looks completely normal, and the echo, all the measurement looks like stands out, right? But the only thing that which kind like if you look into the guidelines for prosthetic mitral valve or mechanical valve, whatever you follow, like her peak velocities are not high enough, but her mean and pH and the pressure half time are concerning for possible thrombosis, right, or mechanical or obstruction. Uh, um, yeah, so I like when I think a little bit about that. Okay, when we're gonna do a TE, right? So this is kind of like when I think a little bit about mechanical valves, and thinking a little bit about and the Doppler for the echo. I don't see I see there's a lot of shadowing as you alluded, but the peak velocity is not high enough. Think me a little bit the other parameters, and you integrate all of that, and you think, okay, I think we should get more information. If she's not pregnant, some people can think about doing a cardiac CT or a cardiac MRI. Cardiac CT probably going to be better, or of course TE. I think that's going to be in my next step.
Okay, perfect. I think we had few thoughts in common. I'm not sure what do you exactly mean with high enough peak velocity. Do you have a certain threshold that you mean?
2.5, usually 2.5, which a lot of the guidelines recommend. Like if you think a little bit about like peak velocity for prosthesis, right? Normal usually less 1.9. If it is
I'm
significant,
familiar with 1.9.
yeah, and then if it is more or equal 2.5 was like suggest significant stenosis. In between 1.9 and 2.5 possible stenosis, but also you put the mean gradient, you put the pressure half time, you calculate the VTIs, the mitral valve over the LVOT VTI, and if it is above
2.2.
yeah, and how much the VTIs?
It was 1.9 in our case.
Okay, so even like the the VTI, you mean the ratio?
Yeah, I mean the ratio. LVOT over the mitral over the LVOT.
1.9?
Yeah.
Yeah, and that is below 2.2, which should be normal. So you have a little bit of discrepancy, high gradient, mean gradient 16, right? And you have a pressure half time with more than 200, which is significant. And you have a little bit of and a little bit lowish peak velocity. It's not exclusion, but make me think a little bit about. I like to see the peak velocity a little bit above 2.5, but 2.44, I think it's close enough to think a little bit about this valve has a problem,
Okay, this is a very important point to highlight that the absolute values that we are talking or we are memorizing or reading from the guidelines does not really dichotomize the patient. This is a spectrum. We are just picking a value to get the majority of the patient on one side of the diagnosis, but there is a spectrum of values. There is no real values that dichotomize the patient. Okay.
Do we have an effective orifice area by continuity equation?
Unfortunately, we did not do that because I'm not sure why we haven't did that at this stage, but later on we found that we don't really need it because of two things. We assumed that the patient just had the surgery, a proper prosthesis for her body surface area was selected. It's unlikely that we have a PANAS, and we had a very perfectly opening and closing prosthesis. We should have done that, but as we proceeded, we found that it will not add a lot to us, as you will see. But we should have done it, of course.
Because, as you know, the pressure half time method to calculate valve area is not validated for
We did not
mechanical or prosthetic valves. Yeah.
Definitely, we did not rely on that. Okay,
Gotcha.
definitely, you're absolutely right.
Waiting for the TE then.
Okay. Okay, let's see how we proceed.
Before we move on, can I see some comments, Ahmed, please? Before it gets more complex.
Oh, yeah, sure.
Yeah. So, how much warfarin was she on?
6 milligrams.
6 milligrams. So it's over 5 milligrams, which is the cutoff we think about.
Exactly.
Okay. So 6 milligrams. And her warfarin, was it weight based when she was switched to Levonox? Was it weight based, or were they
She was
checking
62
10A?
milligram. She is 62 milligram, as I already stated in her examination, and she was switched to 60 milligram twice enoxaparin.
Okay, gotcha. And couple of things. So when she had the hemoglobin of 8, so just
Actually,
don't.
I think
Yeah.
This was our reading when she first presented to us, and tracing back her old labs, she has been anemic since her surgery, with values fluctuating around the 9 to 9.5.
I gotcha.
So
I gotcha.
some sort of dilutional will add it to her 9, 8.
Gotcha. So the reason I'm saying this, once you do an echo in someone with hemoglobin of 8, you always should expect you have a high flow state across every single valve. That's why it's very important to have your VTI across LVOT and across whichever valve. So Dr. Sami mentioned the DVI on this valve. That was a very good point, because you're going to have a high flow state, especially pregnancy as well would be a high flow state. The other thing is, it's good to know what the normal color looks like for such a valve, because you have two bi-leaflets, you have 3 holes. So when it's normal closing, you should expect one central big jet and two peripheral, because it's going to be important if you suspecting some PVL or some like a central MR. But the problem what we have when you have mechanical, you have a lot of shadowing. So TEE is absolutely going to be very nice here. Yep, exactly. To Dr. Sami's point, CT, if she's not pregnant, would be excellent. And I think we saw the leaflets moving great on the fluoroscopy, on the basically the X-ray we did. But it would be nice if you're suspecting thrombus versus pannus. We start talking about the attenuation.
Pannus is a little bit unlikely considering her recent surgery.
Exactly, it's 8 months ago. So to have a pannus in such a very brand new valve would be very unlikely. But just for the sake of the discussion, I mean, attenuation definitely would be something to look for. And I mean, her echo numbers to me still don't make sense, so I'll probably wait for the TE and we can pick this up again. Yes, thank you.
Okay. Thank you. Okay. So as we have already almost agreed, we proceeded for TE, but just I want to highlight this. This is more or less similar to the algorithm adopted by the ASE ECAVI combined guidelines. So pressure half time is the gate to start with. It's very sensitive, specific for obstruction. And for us, at least that's our practice. Once we find a PHT more than 130 and the higher, the better for us to dichotomize the patient. It's not very likely that this patient have an obstruction. And then the mean gradient, whether it is high or low, we try to fit in the clinical context. So in our patient, we had a high PHT, 217. We had a high mean gradient, around 16. So we're more or less inclined that we had a pathological obstruction. And we were not that much inclined to attribute this to the high flow state of pregnancy, anemia, or whatsoever. So we proceeded for the T, as we already have been all waiting for. All of the views that I'm showing are mid-esophageal views, with the angle being moved around the prosthesis. I think that starting from the 0 degree, you can appreciate that there is something roofing the atrial surface of the prosthesis, the part that was, as already we have mentioned, shadowed by the prosthesis in the transthoracic. As we move around the prosthesis, it becomes clear here in your left bottom hand that there's something more related to the sewing ring or the atrial surface of the prosthesis. And as we move further to 75, and here we rotated the probe counterclockwise a little bit, become more clear that there is a thrombus roofing the sewing ring. More clear here, even more clear here. There was, at least we can say, that a highly mobile mass related to the atrial surface of the prosthesis, mainly to the sewing ring, because it is not affecting the movement of the occluders. This is 3D, not the perfect thing, but we can see the prosthesis anti-anatomical. Aorta is here, and at the 10 o'clock position, I'm not sure if you can appreciate something here, but it was the largest thing that we could appreciate was in 10 o'clock. This is the tricuspid annuloplasty ring. It has C-shaped annuloplasty ring. So again, this is a female with missed abortion complaining of dyspnea, a non-well anticoagulated mitral valve prosthesis with masses likely thrombi related to it. Dr. Sami have highlighted the possibility of infective endocarditis. Vegetation at the end is an infected thrombus, but to put this into a clinical context, we were not convinced that this is a case of infective endocarditis, considering the lack of toxic fascias that we used to see, the non-striking inflammatory parameters, the absence of leukocytosis, which is a shift, negative blood cultures, and again, the anemia. So what are we, how should we proceed starting from here? Should we go for cardiac surgery or should we conserve on this patient, and how to conserve? Besides, this is not just a case of a thrombosed mechanical prosthesis in a pregnant female. We have another issue, the missed abortion. Should we proceed for uterine evacuation? The thing that she has been referred to us in the first place to assess prior to doing. And when should we do that? Which is which? Anticoagulation, managing the cardiac part first, or managing the obstetric part first? Would you like to engage in a discussion, or?
Well, first of all, I think the adding TE 3D images are very helpful in the situation, and I think this is really what matters, looking more in the structure, and that you guys have a great images. I can tell maybe a little bit if you play with the 3D gain a little bit in and
Yeah.
out will help a lot. Also, I think in these cases, I like to compare the TE that we've done now into the intraoperative TE when she had the mitral valve, if we have access to that. That's very important because sometimes there's remnants of core D, there's threads here and there, there's shadowing and maybe the same thing when she left the OR. So I think the comparison between the intraoperative TE and the subsequent TE will help a lot. But I agree with you, the commercial findings on the TE raised the suspicion. Yeah, there's something happened here, and looks like subacute in nature, something recent. Interesting. Like when we think a little bit about this case, identifying pregnancy and anemia with a normal flow state is very interesting, right? Or high flow state. I think making sense of your flow and VTIs and stroke volume and all of that. But one of the things that we usually see people with normal flow and have all these gradients, PPM, right? But it's too soon to have a PPM in a patient like this. Kind of like I'm thinking a little bit about it. It can be this patient prosthesis mismatch, less likely. Just I'm thinking a little bit about, okay, where is this going to take us? But I think the 3D made it for me at least. So.
Okay.
Ahmed, I have a couple of things after seeing the TE. I agree with Dr. Sami. It was very helpful. 3D is actually excellent. Smoothing and 3D gain might have helped a little. Should we, if we need to discuss going back, a step back about her switching her warfarin or stopping her warfarin, should we talk about this now or should we wait until the end? And because it's a big part of the discussion is what we should have done back in time if she would have presented to you guys earlier.
Actually, okay, just give me a second.
Yeah, for sure.
Dr. Amr, can you please elaborate more about the question you just asked?
Yeah, no, I was saying if we need to talk about if we, in a perfect world, and this patient would come to you guys and telling you, hey, I'm gonna think about getting pregnant, how would you counsel her? How would you counsel her anticoagulation? How would you counsel her risk? What would you tell her? I just want to make sure we talk about this because it's very important. And it's the whole deal out of this case, essentially. But I'll leave it up to you guys if you want to talk about now, or we can talk about this at the end.
Definitely, that's something that should be covered, and I think we will discuss this
Perfect.
definitely. Thank you so
Yeah,
much.
exactly. We'll discuss because this is super
Yeah.
important.
I want to stir a little bit of controversy here. I think I see what you guys are pointing at in the 3D. It doesn't seem to my eye, but I'm looking from 1,000 miles away. It doesn't seem to be encroaching on the actual orifice. So I'm still not convinced why you would have such high gradients because of this finding.
Okay, first, we do agree that we have a high gradient because we have more or less astoundingly accurate measurements. But if it does not encroach on the occluders itself, that does not mean that it does not affecting the effective orifice area.
It's not encroaching on the orifice, not just the occluders. I don't see anything within the orifice of the mitral valve. But
Ahmed,
again,
your
I'm
3D is not.
I mean, the pictures are not great from my end. Maybe you guys see something I don't see.
I think that the mid-esophageal 120 degree, it showed that the part of the thrombus is actually roofing the orifice.
The orifice, okay.
Yeah, I think if you look at your left-hand side, the bottom flap, you can find that there is an elongated part of the thrombus passing above the orifice of the mitral valve prothesis.
Gotcha.
We should have
But
worked
To the 3D
more
picture.
on 3D images.
Yeah, go to the 3D picture, just the 1/3. Yeah, if you just compare the lateral and medial commissures and just away from the leaflets itself, just on, yeah, exactly where you are.
10 o'clock position. If the
Exactly
aorta is
where,
like 12.
exactly
gotcha.
here.
Yeah, I see it now.
It's crowded. There's something there, right? It's not really moving. It's just fixed there. And I think this is where you're right. If you calculate her effective orifice area, maybe okay, but the one that toward that mass is slightly lower, smaller. This is
Yeah.
why I think the 3D here makes the case. So,
Yeah. By any chance, do we have a baseline echo after her surgery? Do we know her baseline gradients and parameters?
Unfortunately, she did not have the surgery at our institute, and
Gotcha.
we did not have a good documentation for her echoes. And we don't have a
Gotcha.
preconception echo even. Okay, you have not answered my question. How should you proceed? Would you evacuate her pregnancy, then proceed for the cardiac issue, or if you like, I can proceed to what we have done, or hear what your insights about that.
I think you need to medically evacuate if there's an option for medical evacuation. You should evacuate. I mean, missed a portion, you don't leave it there for weeks. This is, I think, a biggest issue. So if it was my patient, I would try to evacuate the uterus first. I don't think this patient risk is going to be tremendous. She's young, hemodynamically stable. I mean, these things are done with, sedation, more or less, or medical evacuation would be another option.
Okay.
yeah, I think when I think about these things, like risk and benefits, right? Like, I think it's going to be more complicated if the fetus is alive or still preserved, and then you could put the fetal risk there. But the maternal risk here really and the surgery, and as everyone said, I think we should go. But like for discussion, like what are the options, right? What we do, surgery, move on, or optimize with heparin drip, right? And if we say the surgery does not have to happen, or give thrombolytics, right? And I think if the fetus is alive, let's say that, and he's not really, we need to evacuate here, and the patient is stable, right? Maybe there is a chance for thrombolytics. Low dose TPA has been done with some cases like that. But when you put surgery surgical option, always going to be high risk for the mom, for the baby, and this really reserved for failure or emergency, right? And then the option in between, when I want to go for surgery, I will not go for TPA. I will go for heparin optimization. Always going to be low risk for the mom, because what else is going to happen to the mom? More bleeding, and going to be low risk for the fetus. But I think, if you think a little bit about that approach, what the risk and benefit mom and baby, and then what my option would make you think a little bit about different options. But I think here, I think we should focus on the mom, right? And we should do something. So kind of like we are going for surgery regardless, right? Which is very interesting. Yeah.
Okay.
So, Ahmed, a question. I assume the patient has been sitting on heparin drip since then, right? Until we kind of figure out what's the end game, right? When she came.
Not really. This
So,
patient. Okay, proceed here.
so what do you have her on now? While are you guys doing the investigations for this?
Okay. So I have skipped a small part. So I will tell you what we have done and our rationale for that. So once the patient
Okay.
came for us, she has been assessed by the assistant lecturer on duty, which was me, and we were more or less considering even the transthoracic data that we have an obstructed prosthesis in a non-critically ill patient. So based on discussion with the attending at that night and with the obstetric attending, we decided that regardless of what's ongoing with the prosthesis, patient is vitally stable. We need to anticoagulate here, but at first we need to eliminate the possible bleeding risk. And our colleagues in the obstetrics and the gynecology told us these two things. First, that surgical evacuation, as already you have stated, is a low-risk procedure. It can be done by procedural sedation only without need for general or spinal anesthesia. One. Two, after the procedure by around 12 hours, we should just expect minimal spotting from the vagina, no risk of bleeding, especially if they inserted hormonal IUDs. This will make the uterus less likely to have bleeding. So we decided to proceed for that immediately to neutralize the possible source of bleeding, and then we will be just dealing with the patient as a case of a thrombosed mechanical prosthesis without the extra burden of the bleeding that her missed pregnancy gave us. Otherwise, they told us that if missed pregnancy can be complicated at any point with bleeding, we could have uterine atony associated with that, and here the bleeding would be difficult to control. And we were expecting that our provisional plan, as you already stated, was to proceed with anticoagulation. Then our rescue plan, if we failed, or our bailout would be thrombolytics, as Dr. Sami has already stated, because this is what the literature is telling us that ultra slow altiplase infusion is the more safe. So she didn't receive heparin. She immediately proceeded for uterine evacuation using procedural sedation. Then when she came back, our colleagues assessed the bleeding risk. We just have minimal spotting. We proceeded for therapeutic anticoagulation using unfractionated heparin. Initially, we target a lower PTT, 50 to 70, which is like 1.5 to 2 as the upper EPTT. And our bailout or backup plan was thrombolytics in case if we had hemodynamic compromise. And I already discussed our rationale. We needed to minimize the extra burden that her missed, extra burden of bleeding that her missed abortion might cause us. Unfortunately, this went smooth. We went for DNC. We proceeded for heparin infusion. After that, by around 8 to 9 hours, targeting APTT 50 to 70. Later, we targeted a higher APTT 70 to 90, which is around 2.5 the upper APTT. We had no significant bleeding, occasional minimal spotting that was frequently assessed by our colleagues in the obstetrics, and they used packing. We did serial transthoracic echoes to assess the gradient across the mitral prosthesis. And once we had a combination of subjective improvement in symptoms and a little bit falling, not complete normalization of the gradient, we proceeded for TE. That is what we have done. But I will take you back to what the guidelines actually has to offer about this. So the guidelines, this is from the AEC guidelines. It tells us that once you have a suspicion of a thrombus, you proceed for transthoracic transesophageal fluoroscopy, as we done. Obstructive thrombus, which we had, is a patient critically ill. If yes, on your left side hand, you should be proceeding for surgery if feasible, according to the guidelines. Otherwise, thrombolytics. Going back to where our patient fit in the algorithm. Was she well anticoagulated? Our patient was not. So you proceed for a heparin /aspirin And if you succeeded, well and good. If not, then you again surgery versus thrombolytics according to the surgical risk. And I told you what we have already done for this patient. So this is the follow-up TE, and it was done on the 8th day of admission. Again, these are all mid-esophageal views with rotating the angle around the prosthesis, reminding you that the thrombus was most pronounced around in the 120 degree. We still just have this thing related to towards the left atrial appendage, likely assumption. Otherwise, we had full resolution of the mass that was related to the atrial aspect of the prosthesis.
What's the numbers now on this echo as far as mean gradient and E velocity and all of that?
Oh, I'll show you right now. This is again the mid-esophageal at 120, 140, just washing jets, and this thing related to the atrial aspect, likely, very likely such. So the pressure half time is now, 104, reminding you it was 217, and these are our mean now. It is 7, and the peak gradient is 10. Very comparable. Still, we would like to see numbers below 5, but this is mean. It's the mean. But these are very comparable to what to be expected from a 27 St. Jude. Patient was discharged after 2 weeks. We marathonized her using the same 6 milligram, and her RNR was 3.5. Unremarkable follow-up. Her anemia, her hemoglobin in the last follow-up around 2 months ago, it was 9.1. And that's it for this patient. Actually, we used aspirin along with the warfarin at some point, but then we discontinued that, feeling the high risk of bleeding, considering that she is anemic and her INR has been a little bit labile with us. Okay, so now we can have a discussion of whatsoever you want regarding the management plan, what you have done differently, or we can proceed to a brief review about the things that Dr. Amr have tackled, how to manage the thrombotic issue in these patients, and what data do we have already regarding that.
Yeah, just one comment. It's
Yes,
a great outcome, I think. If you compare the TE, the mid-esophageal one, before and after, just if you think a little bit about the washing jets here, like I know you've been pointing to that thing that close to between the appendage with anterior leaflet. I think this is all post-surgical stuff. I'm not concerned about it. But if you look into the washing jets, this is the normal washing jet. That washing jet was not there when you have the first TE. And that tells you something there improved. The washing, yeah. I kind of like, interesting. Like at the beginning, like when we think a little bit about normal flow or high flow pregnancy and all of that, are we missing a PVL? Are we missing something there? And I think it was not there yet, and the 3D did not show it. I know he did not put color, but less likely 8 months ago. But the washing jets, to me, was helpful. I think if you repeated the 3D, you're going to show that. But I think the hemodynamics improved, the patient improved. So whatever happened, you fix it. So I think that's a good outcome. So I will not do anything different. So.
Okay.
I agree with Dr. Sami. I think the washing jet point is actually very interesting, and I like it. I wouldn't have done, as Dr. Osama actually mentioned initially, before we get into the details of what we do with the valve, medical or surgical evacuation of the fetus that's dead in there should have proceeded everything, and I think that was the right choice and the right decision, and probably I would have done the same. Speaking of, after we kind of took care of the evacuation, what we would have done for the valve, I mean, we got lucky, honestly, with this patient because her CHF symptoms or whatever symptoms she has or she had, it wasn't a lot, right? If we put her on NYHA, she would be maybe class 1 or class 2 symptoms, which is it's kind of fortunate for us because we're not dealing with someone in critically ill. We're not dealing with someone who's in cardiogenic shock. We're not dealing with like a refractory heart failure symptom. So that gives us some space and some time to think about less invasive approach, meaning like heparin plus minus thrombolytic if we have to. When we talk about surgery, I mean, I'm not sure if a surgeon would redo a surgery in a patient unless you have a very, very convincing evidence. This is the only option, and those are usually patients who are very ill, patients who have a very bad heart failure symptoms, big thrombus burden. Like you really gotta convince a surgeon to take this patient to redo surgery in that case. Otherwise, if you look at the guidelines from 10 years ago, like 2014, and you see where the thrombolytic would fit into treatment of this patient, it was actually I think class 2A or 2B when you look at like what should you do with a valve thrombosis. Then in 2017, we got an update on the 2014 guidelines, and it was actually class 1B. And as Dr. Sami mentioned, this is all because the regimen that we've learned throughout the cases that we do the slow dose and also a small dose and a slow infusion protocols. There's tons of protocols out there, but all of them share the same thing, the small and slow. And the big thing to remember here is all of them were done with a serial echoes, which you guys did exactly. You give the dose, you do serial echo, and reassess. Even if you would have ended with given this patient thrombolytic, you would still have to do an echo right after your first dose, and you repeat based on the resolution of your basically clinical symptoms, your main gradients, their numbers, and everything. So I think you guys have managed this perfectly as I would have done, and I think the patient outcome is great. As far as when she was going home, I'm not sure if I would have added aspirin. I know you said we took it eventually off. This patient clearly wasn't compliant, or her INR wasn't really therapeutic to begin with. So optimizing her INR and maybe going up to a higher level or a higher range or higher target, maybe 4, would have been the thing I would advocate for. And I wouldn't have added aspirin unless this patient came in with therapeutic INR. She had a thrombus on top of this. Then I would probably add aspirin. Taking this all the way back to like counseling and what we have done initially to this patient if she came to cardiology clinic, this is also a whole discussion about to happen. So I'll let you guys talk to us about that. Thank you.
Thank you. Yeah, I do agree with you. Actually, in the literature, it was the ultra slow infusion of altiplase was done with serial assessment and even with transesophageal, not just transthoracic echo. In the Troya trial, if I'm pronouncing it right. Second thing is that usually if the patient had an event while well anticoagulated, we go for a higher or a more strict marivanization. But she had the event while not well anticoagulated. She had a hemoglobin of 9, which put her at a higher bleeding risk if according to the ARC criteria. So we found that 3.5 would be perfect for her. And we removed the aspirin as we already stated. And she's doing well so far, and we will see.
If I may add a few points, just as a follow-up, and I want to explore, how you guys do things as well. In terms of diagnosing this patient, I think this was pretty easy and straightforward. Recent valve, subtherapeutic INR, high gradients. I think it was a kind of slam dunk. Even if you don't do a TE, it's probably a thrombus. When you get to somebody who's been appropriately anticoagulated, not a fresh valve intervention, I think it gets more interesting, especially when you have an aortic position where you can't really define or see the valve very well on echo, regardless of whether it's a surface echo or a TEE. The shadowing will still be there. In a lot of situations, you cannot see the thrombus very well. And I want to engage the panelists in this as well, is, in terms of utilizing other advanced imaging modalities, right? In terms of utilizing, there's a lot of data coming up about, computer tomography, actually CTA, not just, dry CT when you look at the valve, opening, but CTA when you can actually see, a mass, a pannus or a thrombus. You can actually, do a Hans field unit analysis, and this is going to give you a good idea of whether you're dealing with a thrombus versus a pannus. What has been your experience in your institution about utilizing these modalities and making a diagnosis in not as straightforward case as this one?
Okay, so be honest, our workhorse where we work at K University is the thing is that we can, as cardiologists, do by ourselves, which are more feasible, more available. Fluoro, echo, and transvaginal echo. In rare instances, which is not our routine at all, we go for CT, especially when we are not sure what's exactly going on. When we have a high gradient and we see nothing by transfusing, we see nothing by transesophageal, and we need to have an explanation when we are suspecting PANAS, for example. So at these instances, we proceed for CT. We don't have a broad experience with it, but it is just when we don't have an explanation. And I don't think it is, in many instances, the echo provide you with the answer. Tell me, other than PANAS, what exactly are you expecting to find with CT that echo transesophageal will not be providing you the answer with a reasonable sensitivity and specificity?
But that's the wrong question, if I may, right? Here you're talking about standard of care, and I see this board opportunity, this discussion, not just an opportunity to, educate and discuss cases, but how can we help in transferring some of the standards that we use here? Because you guys have the CAT scan, right? But you might not have the ability to, look at the valve and see if this is a thrombus or PANAS. I mean, the implications are great. You're basically avoiding surgery if it's a thrombus by giving thrombolytics, versus you have to commit the patient to a redo surgery they might not even be a candidate for. So again, I see this venue as an opportunity, right? If at Cairo University you're unable to use, the standard of care of today in investigating these valves by computer tomography, maybe, we can invite someone to come here, and this is for ABCDE to look into, right? Invite you, Ahmed, maybe, come, watch maybe Dr. Sami. I know Dr. Sami has a, experience with, computer tomography, cardiac computer tomography. Maybe you can, learn from him and transfer that knowledge back home. Or maybe Dr. Sami can go to Cairo University and teach people how to look at, how to do the exam, how to interpret it. I'm using this venue to stir these kind of, thought processes.
Okay, I agree with you. This is would be actually we have 1 or 2 persons at our department who are experienced with CT, but as I said, we don't have a huge experience with it with our patients who are admitted at our institute. Every now and then that we use it. So it would be great if we are being offered.
These are rare. These are rare cases. They're not very common. And the fact that we don't implant as many mechanical valves in this day and age as we used in the past makes it even more rare. But again, apply this to everything else. Again, I think we need to use this venue as looking for opportunities, not just to have a nice conversation for an hour, but look for opportunities. How can we, as a cardiology community, how can we deliver better care for our patients in Egypt, right? And I'm just bringing this up for all of us to think about, and for Ahmed Shib, who's the representative of the organization, to start maybe bring this up to the board of ABCDE. How can we maybe sponsor someone to travel and learn a new skill or a new technique, or how can we sponsor somebody from the panel to go back and teach people how to do things that are maybe we don't have much experience with. This is not special to this situation, but this is, I think, this is the mentality we need to have.
Okay, this is very very generous so far, and we should.
The last time we
can I add one thing, just one
Yeah,
comment?
go
Like, I
ahead.
think when we talk about mitral valve and rheumatic stenosis, you guys لازم تعرفوا ان انتوا the expert of the ward of rheumatic fever and rheumatic mitral valve. And when we sit in the podium, we talk about all of this, believe it or not, no one have that experience. This
Dr.
number
Sami,
one.
you're so right about this. We just had 2 rheumatic MS last month, and that was the first 2 cases, I think, in 2.5 years for some of the most senior cardiologists in where I am.
100%.
They just don't see this. You guys.
And then, and you have to take this opportunity. I understand the some of the limitation that you guys have, or maybe the CT, all this discussion, but honestly, in clinical cardiology, what's been done, I think, in a lot of academic places here, مش هيعملوا أكتر من اللي انتوا عملتوه, to be honest. Now, back to the academic discussion about PANAS and the CT and the value of that. People argue actually in what you see on the, for example, the CT is a true PANAS, maybe low threshold thrombus. People argue that 3D can have a better delineation, but we discuss that all the time, right? Can you differentiate PANAS on imaging? No. The answer is no. Maybe CT can help, and depending where do you go between different platform and what software you use and how you process and all of these things. But also that maybe open the door. For example, you guys should publish your experience in these cases, right? You can do like a case series, you can put it in the JACC imaging or whatever, because no one have that experience. And that actually the platform and the discussion that moving things forward, how we can make this experience go to the world outside beyond the case discussion here or a grand round or whatever. And I agree. I mean, there's a lot of opportunities into that can affect the guidelines. You can have your Egyptian guidelines. Sometimes when we think a little bit about our Egyptian experience, it's very fruitful. And people don't have it, and I think you should think about it this way. But in terms of the clinical use and the workup for this patient, I think you guys did the right thing to be done. Could something else be done? The add of the CT, I really don't think gonna change the management, in my personal opinion, because I'm really convinced with the 3D. So that's me. But yeah, I think you give me a lot of research idea that actually I want to think a little bit about it, and we can offline all of this. But I will leave it to you. Go to the presentation. Go to the meet. Go. Sorry.
So Dr. Osama, if I may add, I think after the last session, we discussed the possibility of having like maybe some sessions dedicated for discussing the basics of CT and basics of advanced imaging. I think Dr. Sami was very happy with this idea, and he suggested this. And yeah, I think we should implement this.
Just to understand, Osama and Ahmed, as I understand, like you said, it's just like one person in the Cairo University who can read the CT scan, or
No. One person in
it's not
our
this way.
department as a cardiologist, but as a radiology department, there are like 2 to 3 person who go into this business. But we have a perfect cardiologist, Dr. Samah Al-Qaffaz, who can he's very, very good at interpreting various modalities of cardiac CT as a cardiologist. But the CT in our institute, CT heart, is done mainly by the radiologist. And that is why our preference for the things that we can do, because much easier, less time consuming, fluoroscopy, echo.
I got it. So
We're
is there
certainly
any
open to the possibility of having Ahmed going to the US and coming back with all the expertise.
with the CT machine.
تعالى يا عم، تعالى ايوه، ناخدك، تعالى انت بس تعالى.
ماشي.
طيب، هو ده يفتح لنا مجال تاني للنقاش في ما يخص التريننج او كده، فده ممكن نتناقش فيه يعني باستفاضة شوية. بس هو الوقت مش هيسعفنا قوي يعني، ولكن ممكن نحدد سيشن منفصلة يعني، يكون دكتور أسامة، دكتور أحمد سامي، دكتور عمرو، ومعانا أحمد أسامة وأحمد خليل كمان يكونوا موجودين معانا، ونشوف ممكن نقدر نعمل ايه يعني. سيشن مش ساينتفك بس.
تقصد
يعني
بنشرح موضوع مش بنبريزنت كيس. ده كان
بالظبط
يعني
يعني
الموضوع ده المره اللي فاتت.
بالظبط يعني ممكن، بس هي فريندلي سيشن كده، نشوف ممكن نقدر نعمل ايه لموضوع زي ده يعني. هل في opportunity ان احنا نجيب ناس من مصر ان هم يعملوا حاجه زي كده؟ ما عنديش فكره هل نقدر نعمل حاجه زي كده ولا لا، او العكس، ان يبقى في حد من الاتندنجز اللي موجودين هنا يروح كايرو يونيفرسيتي ويعمل حاجه زي كده. فديت مجالها تبقى النقاش، ممكن نعمل لها سيشن لوحدها. وشكرا دكتور اسامه ان حضرتك طرحت الموضوع ده، يعني أنا شايف ان هي دي نقطه مهمه جدا، وده الهدف اصلا من الاورجنايزيشن ده. هو مش مجرد بس ان احنا نبريزنت انترستنج كيسز، لا، هو نطلع افكار يعني ازاي نغير، وفي نفس الوقت زي ما الدكتور احمد سامي قال، انا شايف ان هو مثلا موضوع الروماتيك، انا بقالي 3 سنين ريزيدنت هنا، انا عمري ما شفت الروماتيك هارت ديزيز لحد دلوقتي. فيعني هو دي حاجه فيري رير ان احنا بنشوفها هنا، فدي حاجه احنا ممكن نستغلها في كايرو يونيفرسيتي، ان احنا ننشر ابحاث عن الحاجه دي. واعتقد ان في ناس كتيره جدا يعني انترست ان هي تنشر، او ان هي اللي عايز يكمل في مجال يعني نيجي هنا او كده. ففي ناس كتيره من طلبه كتيره بتبعت لنا مثلا ان هم عايزين يعملوا ريسيرش او حاجه زي كده، فممكن ده يبقى مجال ان احنا نديفلوب حاجه زي كده يعني.
هي يعني الابلكيشنز هنا يعني ملهاش حدود. احنا
مهم.
واللي انا قصدته مش ان انا اعمل شيمينج للي انتوا بتمارسوه، بالعكس والله. يعني انا حتى ما يعني الكيس اللي فاتت I'm still very proud. يعني you did everything by the book. I'm just trying to plant the seed that this
مهم.
is what we need to think about. Not specific to
مهم.
this case, not specific to Cairo University, not specific to this panel, but in general, utilizing ABCDE, utilizing this great organization in that fashion, not just to present cases, but we think beyond that.
مظبوط.
Okay.
تمام.
Okay,
نرجع.
shall we proceed to a brief review of the literature?
تمام. Go ahead.
Okay. So I'm not sure who first said this, but I think every cardiologist knows this sentence, that prosthetic valve exchange a native disease with a prosthetic prosthesis related complication. Whatever this complication may be, whether it is a thrombus, it is a panus in the long-term implanted prosthesis. In C, you can see this is a Yorkshire drawn from the market in the 1980s because of stress fracture. D, this is a degenerated prosthesis. So prosthetic valve thrombosis is our scope here. There are a lot of complications that can occur: thrombosis, bleeding, infective endocarditis, paravalvular leak with what it entails of hemolysis and anemia. But our scope is focus is prosthetic valve thrombosis here, so that is what we will be talking about, and particularly prosthetic valve thrombosis in the pregnancy. So the annual rate of thrombosis in the St. Jude, whether it's aortic or mitral, is around 0.1 to 0.3. St. Jude is the most commonly implanted in Egypt. I have seen few carbomedics and very, very few onyx. And when to suspect clinically symptoms, the patient with a prosthesis who start to get dyspneic, who have limited functional capacity, and by echo the increased gradient across the prosthesis. And for every prosthesis, every position mitral aorta, we have our values for suspecting thrombosis. And usually we have a lot of modalities for imaging. Fluoroscopy, usually the mitral is visualized in the REO with its variable inclination, and the aorta in the LAO views. And transthoracic/transesophageal echo, recognizing the limitation of the transthoracic, especially in the mitral, because of the shadowing artifact in the atrial surface of the prosthesis. As in our case, we could not visualize the thrombi related to the atrial surface. Aorta, as Dr. Osama has stated, usually difficult to assess even by transesophageal echo. And finally, as you already stated, the multi-slice CT. Presenting few examples of that, this is the case that we have seen at our institute, female with cardiogenic shock, and she had aortic prosthesis. I hope you can appreciate here one of the occluders is clearly stuck. This occluder, the other is moving with transvalvular regurgitation. Increase the gradient. Fluoroscopy. This actually is the fluoroscopy of the previous female. You can appreciate this is one of the occluders is moving, the other is completely stuck in the closing position. This is again an aortic valve. Two occluders are moving, but I think if you are familiar with that, you can appreciate that this opening angle is not the normal one. The two occluders are not the parallel, at least the 13 to 18 degrees that you are expecting to see. This patient had a panus. This is Yorkshire. We see it from every now and then. Not that rare as we used to think. I have seen like in the last 6 months around 3 cases, and it is well functioning in this view. The angle is usually around 60. Very challenging to recognize, especially that we are not familiar with it. Occasion, sorry for the voice. Occasion pole, not very common to see nowadays. So again, our scope, as I already stated, is mitral prosthetic valve thrombosis in a pregnant female. So the question from the start: should a female, with a mechanical prosthesis get pregnant? This is a difficult question to ask with no exactly clear answer. But apparently patients with mechanical prosthesis get pregnant. So this is something that we have to deal with. The guidelines for the valvular heart disease or the guidelines for the cardiovascular disease in pregnancy categorize the various cardiac condition into the modified WHO criteria from 1 to 4, according to the risk of having an event during pregnancy. Mechanical prosthesis are modified WHO 3, which means that the chance of the probability of having an event is around 20 to 30. And this necessitates experienced counseling in an experienced center with dealing with prosthesis. As with everything in pregnancy, we lack randomized trials. So most of our data would be derived from retrospective registries and observational studies. But luckily in pregnancy, we have the ROPAC registry of pregnancy and the cardiac disease. It is mainly was initiated as a European, but now it includes 160 countries, starting to collect data from 2007, and Egypt is one of the top contributors. Likely because we have a lot of females in the childbearing period with cardiac diseases. A lot of them have rheumatic disease, many have congenital heart disease. So actually they published a lot of papers about the various cardiac diseases in pregnancy. And in 2015, they published their data about the mechanical prosthesis in pregnancy. And this was the editorial, Mechanical Heart Valve in Pregnancy, a Sticky Business. And it's actually a very descriptive sentences. Let's see why it is a sticky business. So they had 212 patients with mechanical heart valve and compared their outcome to patients with tissue heart valve and to patients with cardiac diseases but no prosthetic valve in general, whether mechanical or tissue valve. And only 58% of the female with mechanical heart valve have an uneventful pregnancy. Translating this into another, it is very likely that 4 out of every 10 patients will have an event. Events varying. Maternal mortality 1.4. It might seem as a small percent, but compared to the usual or the expected mortality in the normal pregnancy, it is about 30 to 200-fold higher. Mechanical thrombosis in 4.7% of patients, hemorrhagic event in 23% of patients, and pregnancy loss in around 20% of patients. This is strikingly high, very high numbers compared to 1, the normal pregnant population, and 2, even to the patient with cardiac disease but no prosthesis. Just have a quick look at this table. This is the odds of having a complication in a patient with a mechanical prosthesis compared to a patient with cardiac disease but no prosthesis. Everything is strikingly higher odds ratio, and these are only the statistically significant values. For example, the thrombotic events, the odds ratio of having a thrombotic is 17 times higher. Hemorrhagic events around 6%, 6 times higher, I'm sorry. Everything is strikingly higher in the patient with mechanical prosthesis. That's why, again, this is a very sticky business. I put this in a particular slide. They have compared the outcomes in the emerging, developing country like us and the developed country. And they found no statistically significant difference in the thrombosis, miscarriage, and fetal mortality. I translate this into, and this is not just a resource problem. This is reflecting the inherent issues that we have in the medical management and the medical paradigm in general. We have medical issues and we have a dilemma in dealing with such patients that extend beyond the availability of particular resources. The decision making itself is not clear to us all over the world, not just here as a developing or emerging country as they. One of the main issues in pregnancy, as Dr. Amr, I think, have tried to talk about from the early start, is anticoagulation. Anticoagulation in these patients, we have to weigh 2 things against each other, the mother and the fetus. So what options do we already have? We have warfarin, we have the heparins. We know that the rest of the anticoagulants are not validated for patients with mechanical prosthesis. Warfarin, I can describe as good for the mother, bad for the fetus. Good for the mother because it have the least possibility of having a thrombosed prosthesis, bad for the fetus because it was associated with a higher percentage of miscarriage, fetal embryopathy, which is the classically described warfarin embryopathy of nasal hypoplasia, bone stippling. However, this is dose dependent with values less than 5 milligrams, as Dr. Amr tried to mention earlier in this session, was found to be more or less safe. Heparins, not teratogenic, but there is actually this issue with trying to adjust the proper dose because of his pregnancy, increased renal clearance, volume of distribution. So we have to monitor factor 10. Heparins, very same thing, not teratogenic, but needs hospitalization, which is quite not doable thing in our resources. Propacogesti tell us a very simple data. No superior anticoagulant regimen. You are gonna treat something with something, trading the mother safety with the fetal safety, or vice versa. VKA, higher rate of miscarriage, later fetal loss in pregnancy, but on the same time it was associated with less thrombotic events. Heparins, they found that all the thrombotic events that occurred in the first trimester was in patients who are switched to heparin. What does the guideline tell us? Actually, the guidelines tell us what not to do with clear certainty. Do not give a low molecular weight heparin if you cannot monitor anti-factor 10. Do not give the NOACs. Do not give the Bigatran. But with much less certainty, the guidelines tell us what to do. The guidelines tell us that if the patient cannot monitor her, if the patient cannot well anticoagulate it, she should advise against pregnancy. But if the patient can monitor her anticoagulation, first check the warfarin. If the dose is less than 5 milligram, if the dose is less than 5 milligram, we have two options here. And I want you to observe these are all yellow and orange colors of the class 2A and the class 2B. We don't have certain data. We don't have prospective randomized data, and everything here is just should be recommended. If warfarin less than 5 milligram, we can continue throughout the 3 trimesters, because the data that we have that these doses does not eliminate the risk of warfarin in perioperacy, but reduce it to less than 3%. Other option is that we can switch to low molecular weight heparin during the first trimester and then continue to warfarin. If the dose is more than 5 milligram, again, the guidelines tell us, can you monitor the anti-factor 10 for low molecular weight heparin, a practice that we usually do not do for patients who are not pregnant. We just give them the therapeutic dose of heparin, 1 milligram per kilogram every 12 hours. If you can monitor it, you can give heparin first trimester, then switch to warfarin again, or heparin throughout the 3 trimesters. If you cannot monitor it, it gives us a more impractical, unrealistic solution, at least for us here in Egypt. Admit the patients and gives them unfractionated heparin with monitoring of the ABTT. We have a lot of patients with mechanical prosthesis who are pregnant, and in our resource, even in Cairo University, we have a huge capacity before delivery, or patients will be taking heparin regardless of the type. 36 hours is unfractionated heparin, 4 to 6 hours discontinue anticoagulation and proceed for pregnancy. So we have 3 options. Use heparins throughout, knowing that you are exposing the mother to high risk of thrombosis, especially in the first trimester. Use VKA throughout, especially if the dose is less than 5 milligram, knowing that you are exposing the fetus to an increased risk of imperiopathy and miscarriage, or sequential therapy, depending on the warfarin dose, less than 5 milligram using the first trimester, then you can switch to heparins. This is the same guidelines from the European. So again, when I look to this algorithm, it is a completely impractical algorithm to us, and we have our own a little bit different practice, and we are trying to have a study to see if we can apply it. Well, actually, one of our professors who are specialized in this use unfractionated heparin subcutaneous at home, and they monitor it by ABTT every 3 days, trying to achieve a therapeutic level. And we have a thesis of one of our colleagues that's going right now with a little bit promising result. And I want to highlight that this have been tested previously, older data from Mexico, and they failed to show a probable or a satisfactory data. But in this study, there was a lot of Cajun Paul, a lot of Yorkshire prosthesis back late in the 90s. Now we have the St. Jude prosthesis with better thrombogenic profile. So we are hoping to find a better data that fits our economical status. Last slide to talk about the Dr. Osama, I think, have already stated, have been talking about, is that thrombolysis in pregnancy. Contrary to what we intuitively like to think, that you should not be giving thrombolytics in pregnancy, thrombolytics in pregnancy is more or less safe. So this is a sub-analysis of the Troya trial of the pregnant females. They had 24 pregnant female with mechanical heart prosthesis. They used the low dose ultra prolonged infusion over 6 hours, repeating if they needed, up to mean dose used of 50 milligram. And all the patient had complete thrombus resolution. Only one female had placental hemorrhage. So proceeding to take home messages, Mechanical heart valve and pregnancy is a bad mix. Sticky business, as the circulation have told us, need experienced counseling and meticulous follow-up. Anticoagulation, warfarin is not to be completely omitted, knowing that it carries the better prognosis for the mother, a little bit lower risk for the fetus if less than 5 milligram. Aspirin can be a good friend, plus 2 be in the guidelines. Symptoms of prosthesis malfunction can sometimes overlap with those of pregnancy, so we should be having a low threshold for investigation. No one size fits all, and we should be trying to individualize based on the clinical context and the clinical scenario and the local expertise and the availability of resources. And that's it for me. I hope that I have not talked a lot.
متشكرين جدا دكتور أحمد، ما شاء الله يعني برزنتيشن جميلة جدا. ودايما جامعة القاهرة دايما مشرفانا، إذا كنت حضرتك أو أحمد أسامة. ربنا يكرمكم دايما بإذن الله، ومبروك لأحمد أسامة إن هو ماتش. فمش عارف أنت مقدم أحمد ولا
السنة الجاية إن شاء الله.
لا أنا ما اديتش السايكل دي.
طيب ربنا معاك إن شاء الله، بالتوفيق يا رب بإذن الله.
Before you end, I just want to ask you about what do you do for these patients in your practice?
هو السؤال ده للبانلست، أنا لسه ريزيدنت فيعني.
Okay.
بالنسبة للpregnant ولا
Pregnant.
overall؟
For this pregnant patient, what anticoagulation regimen do you use?
Exactly what's recommended. يعني what you described in the guidelines is what's been practiced.
Enoxaparin
But in terms of in terms of valve thrombosis in pregnant females, I don't claim to have a big experience with it. I had one case, a young lady, very high. She was aortic mechanical valve, and she came in with valve thrombosis, and she responded really well, and she had a viable pregnancy. I think she was maybe 24 weeks. Yeah, we did the ultra low dose, the 25 milligrams over 6 hours, and we repeated. I think we gave her 4 or 5 sessions, daily sessions. No bleeding. We got her to delivery, viable fetus, and she did really well. And she probably had a mixed. She was far out from implant. She probably had a combination of a pannus and a thrombus on top of it, because the gradients never went away completely. And as you know, having a pannus can increase the risk, or one of the risk factors to having valve thrombosis. So she probably had the 2 elements. So we did the thrombolytics. She did well. We got her to delivery, and there was a residual gradient, and we recommended that she proceed with surgery later on. But again, we don't. Again, mechanical valves are not that common anymore, especially in outside of emerging countries or developing countries. We don't have a lot of rheumatic fever, so most of our patients are older. She was actually Hispanic. I think she was from Mexico, and that's how she got. I think she grew up outside of the U.S. So we don't see a lot of young females with mechanical valves. And I think, to the point of our other panelists, you probably have more young females with mechanical valves than us in North America. But the data is very promising. There's a lot of good data from Turkey now, saying that the ultra low dose has good outcomes.
2013.
And I think I can't remember the guy's name, but he published a lot on
Oscan
this.
or something like that.
Oscar, yeah, or Oscaran, something like that. So he published good data, good results. The only concern is the risk of recurrent thromboembolic events and valve thrombosis in these patients can be as high as 30% within the first 2 years. So that would be the only downside of keeping that valve and just do thrombolysis. But I think we're going to see more and more people trying thrombolysis in these patients than taking them straight to surgery, especially pregnant females.
Okay, and your patient was vitally stable from the start.
She was not crashing and burning, so she was not in shock, but she was I think she was anyway HA class 3, if I remember correctly. It's been a couple of years now, but she was in trouble.
Okay.
تمام، شكرا جزيلا دكتور أسامة. دكتور عمرو، دكتور أحمد سامي، any comments؟
great presentation overall. I think لو نعرف نعمل folder جوجل folder الكيسز اللي احنا اتكلمنا عليها بالاducational material عشان for subsequent people to have this material available. ده هيبقى very helpful. بس يعني
تمام.
I learned a lot today from you guys, يعني from mechanical valve and all of these things. And by the way, even like in the US here, or even Europe, sometimes a lot of places here they don't have, like we think we follow all the guidelines. أتكلم على أمريكا مثلا يعني a lot of people do, not everyone, right? And there's a lot of debates about these things. We have two cases, and I live in a place. There's not really which can. It's not Boston, it's not Chicago, right? But we have two cases actually with valve thrombosis and second and third trimester. And the decision was to proceed for reduced surgery. They did well because the surgeon experience in that was great. But also in my fellowship, we have a couple of cases. I think one we did the heparin drip, and the other one we did with the new TPA. But I think all of these things really have to weigh the risk and benefits, and you have to look what the outcomes here and there and try to do your best. There's no right answer, but I think these things, it's a learning experience, and there's no right and wrong or where you live and what you do. I think at the end of the day, your discussion with patient, with family, it's gonna take a team to come with the right decision, and I think that's the message here. So, yeah, good job.
Okay, thank you for your input.
تمام. دكتور عمرو، تقريبا حضرتك كنت عايز تقول حاجة؟ تمام. هو الصوت مش واضح بس. تمام. هو في النهاية شكرا جزيلا يعني على وجودكم معنا، وبصراحة أنا اتعلمت كتير. أنا ستيل ريزيدنت يعني، بس يعني كل مرة بحضر الموضوع ده بحس إن لسه فيه كتير قوي عشان نتعلمه. فشكرا جزيلا لكم، بالتوفيق يا رب بإذن الله. في حاجة أخيرة بس، هو خالد معالي معانا، هو second year internal medicine resident في شيكاغو. كان في announcement بس كان عايز يقوله قبل ما ننهي السيشن.
Thanks, Dr. Ali. Hello, everybody. This is Khalid Ali. I'm second year resident here in Chicago. I just want to add 2 points and a suggestion. So the 2 points that we are planning to hold the next session on June 21st, I would like to know the availability of our panelists at this time. It's going to be Saturday also. And also, we are starting the fundraising for the like the mentorship program, and also the grant program we do for the match applicants this year. We usually support 5 applicants for the residency application. We hope we'll increase it to 7 or even more. So I will like add the link for donations in the chat for this meeting. And also, if you are not using PayPal, you can reach out to me on my personal email, and we can figure out another way of donation. And thanks everybody for being here today. I learned a lot. I work in a place that's a little bit small. We don't see this kind of patient, like complicated patients. So it's a very good educational case for me. And one of the suggestions is like a little bit of academic suggestion that while I was in the recent ACC, I saw that the Arab American Society of Cardiology, they have something called like fellowship application mentorship. They have like every resident who applies for cardiology, they will assign him to 1 or 2 mentors in cardiologists already. They mentor him through the process, and they start like in May before the application. I will suggest for our like ABCDE mentorship program, we can start with residents from the first year. If someone is passionate about cardiology, is interested and can apply, we can start from the first year like assign him to a mentor, and then starting the process of like how to improve your CV regarding doing the chief, working like in committees in the hospital regarding cardiology, QI projects, and also research ideas and all things. Because for me, it's a personal experience that I didn't know a lot about like how to deal with these things until it was second year, and it's already late for me. So I think it would be a good idea in the future to start with people from the first year, because first year like goes so fast. You suddenly your second year, and then you apply, and then you figure out this. I have like I should have done this. I should have done this. And yeah, we can plan for this in the future. And for our panelists, if they like will check their availability and let us know later, or if they know their availability from now, please let us know. And thank you so much for being here today, and thank you to our attendees.
شكرا خالد. هو بالنسبة لموضوع المنتورشيب، احنا اوريدي عندنا منتورشيب، بس ده المين للناس اللي هم بيقدموا على الريزيدنسي. فاحنا ابلايد الموضوع ده قبل كده، وكنا بنعمل كذا سيشن مع الناس اللي هم مقدمين على الماتش في الريزيدنسي، والموضوع كان لقى فيدباك كويس من ناس كتيرة يعني. بس هو يعني احنا still expanding يعني. بالنسبة لموضوع المنتورشيب، بالنسبة للفيلوشيب، فهي دي فكرة كويسة جدا. أنا عارف إن هو الأرب سوسايتي في كارديولوجي هم بيعملوا الموضوع ده. أنا برضو لما قدمت ما كنتش أعرف عن الموضوع ده، أو يعني ما كانش حد ليا منتور يعني إن هو يدلنا على الموضوع ده. ولكن دي فكرة يعني ممكن نأبلاي في الجروب بتاع الواتساب. ممكن دكتور أحمد سامي يساعدنا في الموضوع ده، دكتور أسامة كمان، دكتور عمرو. لو نأبلاي الموضوع ده بالنسبة للريزيدنتس اللي هم حاليا بيقدموا على الفيلوشيب، فده هيبقى يعني فرصة كويسة بإذن الله. بالنسبة لي الجوجل درايف، او اللي احنا هنحط فيه الحالات الانترستنج اللي احنا عملناها برزنتيشن دي، فاوريدي احنا عندنا جوجل درايف. فاحنا ممكن نستغل الموضوع ده. الجروب الاي تي اللي معانا ممكن يعمل حاجة زي كده، بحيث الحاجات دي تبقى موجودة فور فري لأي حد حابب ان هو يضيف حاجة زي كده. دكتور احمد سامي بيقول happy to help. هو الفكرة بس ان احنا مش يعني هيبقى في اوفرلاب شوية ما بين الارب سوسايتي والاي بي سي دي كارديولوجي بورد. فدي نقطة هنناقشها يعني. ممكن نعمل سيشن تانية كده ما بين الباناليست والكوردينيتورز او المودريتورز الموجودين معانا، وممكن نشوف ايه اللي ممكن نعمله في الموضوع ده. any comments؟ تمام.
اوكي انا برضو يعني ممتن الصراحه للفرصه، وان انا يعني اخد تشانس ان انا بريزنت، وان انا يعني يبقى في تعامل مع حد من باك جراوند ومنتاليتي مختلفه. فيعني حضرتك دكتور شبل، دكتور اسامه، استفدت منك النهارده فعلا، ودكتور سامي، ودكتور عمرو. انا ممتن الصراحه للدiscussion، وخوف الصراحه انها تتكرر يعني ان شاء الله، واجي اتعلم سي تي عندك.
احنا اللي ممتنين
والله
ان في اتاحه للفرصه ان احنا نتواصل معاكم ويبقى في تبادل للمعرفه. احنا
بالظبط
بنتعلم منكم زي ما انتم بتتعلموا مننا والله.
بالظبط. احنا زي ما قلنا هي شير اكسبيرينس بين يعني مصر وامريكا. يعني كل واحد عنده اكسبيرينس، فاحنا بنحاول نفاوند يعني جراوند ما بين الاثنين. فشكرا جزيلا يعني.
شكرا لكم
آه
جميعا.
تمام. شكرا جزيلا. بإذن الله السيشن الجاية هنحاول نشوف لو نعرف نخليها كل شهر يعني. لو قدرنا نعمل كده، أنا عارف إن معظم البانelists هيبقوا مشغولين، ولكن خلينا نشوف كده على الجروب لو ده ممكن يبقى فرصة كويسة بإذن الله.
عايزين جراح يا شبل.
حاضر. حاضر.
كان هيبقى ليه رأي مختلف النهارده.
لا يعني هي الفكره في المالتي ديسيبلينري ابروتش.
Yeah.
يعني عندك حد ايمجر، عندك حد هارت فيلير، عندك حد ستراكشرال، عندك حد سيرجن، وما شاء الله موجودين يعني لو تحب ممكن حتى نتواصل مع حد فيهم يعني السيشن الجاي، لو
خلاص.
تفكرني ان شاء الله. بس
خلاص.
it's the idea of having these multidisciplinary
Yeah.
kind of approach to patients يعني it's very very useful.
ماشي. اكيد باذن الله. يعني هو كل الافكار دي احنا بنطرحها، ويعني بنحاول. احنا كده وصلنا فكرتين اتنين بالنسبه للسي تي وبالنسبه للرايت هارت كاث، فديت حاجتين اتنين يعني. ويل ورك اون ات يعني ان احنا نحاول ناتشيف التارجت ده. فيعني كل فتره احنا في افكار جديده بتظهر يعني، فده حاجه كويسه يعني.
We are doing great والله. ربنا ييسر لكم ويعينكم ويجزيكم خير.
يا رب جميعا بإذن الله، جميعا بإذن الله. ماشي، بإذن الله نشوفكم على خير، وشكرا جزيلا، وإن شاء الله نشوفكم السيشن الجاي. شكرا جزيلا، شكرا أحمد، شكرا أسامة، نشوفكم على خير.
السلام عليكم.
السلام عليكم.
مع السلامة.
عليكم السلام ورحمة الله. مع السلامة.